This presentation was recorded at the 2015 ANZICS ACCCN Annual Scientific Meeting.
So it's now my pleasure to welcome Dr. Brent McSharry to talk about paediatric fluid management. Brent's a paediatric intensivist at Starship Hospital and he has a very strong research focus. He's the only person I know who walks around with carrying a textbook on logistic regression and knows what that word means. He's got a particular interest in paediatric fluid management and he currently has a research grant from the New Zealand Medical Council of New Zealand. He's written the fluid guidelines for the Starship Hospital and he's keen to roll out a national fluid guideline. So he's going to talk to us about fluid management. Thanks.
Thank you, Fiona. I'll try and fly through this so we can get to more interesting stuff. No disclosures. We've got Drew in the audience here, and I still remember being a medical student in '97, and he was telling me paediatricians don't know anything about fluids in children. He was talking about the use of 4% and a fifth, and we'll go through the volumes, and it turns out he was completely right. Those of you who know Drew know he would have used more colourful language than that. But this is the article that led to us giving the wrong fluid and probably killing and harming hundreds or thousands of children over the intervening 30 or 40 years. It's a great article for its era. It's 1950s. It looked at about 70 kids, and if you know what was in hospital, a lot of those would have been elective T's and A's, stuff we do as day cases now. They did come up with this. It's quite brilliant, that the maintenance requirement of water is determined by the caloric expenditure. And a lot of the work of the paper, 90% when you read through, if you add those numbers up 50, you basically come up with about 1 to 1, about for every mil of caloric expenditure you need a mil of fluid. Why is that? Why is fluid related to caloric expenditure? You've got to understand this to understand why we need to move away from these rules nowadays. The alveolar gas equation we all struggled with at university. Remember that 45 millimetres of water vapour pressure? That's coming out of your upper airways, middle airways, completely saturating, and that turns out to be your biggest loss of water in your body. And of course, the more your basal metabolic rate, the more your minute volume, the more water you lose. So it's quite straightforward. You breathe faster because you're bigger, you've got a higher metabolic rate. You lose more water, and it turns out to be about a 1-to-1 relationship in a healthy and well person. They also have a little subset at the end of the paper. It's about 10% of the paper, and they look at the constituent of sodium, and this is what we treated kids for 50 years on, was looking at what the average consistency of cow's milk and human breast milk was, and kind of averaged the two. And if you work that out, it fits nicely to get the sodium requirement in with about 4% and a fifth, and that's why we did that for 40 years before we went to a still fatal but slightly less fatal fluid of half normal saline. And they even point out in the paper how badly or how inaccurate their data is on sodium requirements, but this is quoted to you as law by paediatricians. Some of the reason you need to know this is this all needs to change. Now we have the evidence to change it, and you just need to be a bit armed for telling the paediatricians to go away when they tell you to give less sodium. You need to treat kid fluid much like adult fluids. And it's quite interesting. This is great because the intensivists, I remember my whole training, the intensivists were always saying the paediatricians don't know what they're doing. This is a wrong thing to do for sick kids. We're going to make a small number of them dangerously hyponatremic. What I'm saying, we can't count the teeth. We don't do enough research in kids because kids are special. We're not in equipoise. All this crap. We need to do research in kids. The adults get better treatment because they put them into studies and you find out what's the best way to treat them. And some people were so not in equipoise. This is great. This is when we're moving from 4% and a fifth to half normal saline, saying, and this is published in one of the big journals, at best the excess sodium is unnecessary, at worst it may be unwise, which is the exact opposite of the truth. Anyway, McNabb, paediatrician from Melbourne's in kids, good on it. What we did as intensivists is we argued the point, and we should have seen what she did and just do an RCT. I'll be a very happy person if I ever get an RCT with the primary outcome was hyponatremia, less than 130. That's the most incredible p-value I've seen on a primary outcome in a paper to come out in a long time. So this paper came out. There is no doubt, if you give NON2 compared to giving isotonic fluids, you will see more hyponatremia. Now, this isn't the severe hyponatremia less than 120 because it wasn't powered to detect that difference. You know, they would have had to do. But you can't give hypotonic fluids. Not many intensivists do, but they come up to your ward having had them. After looking at sodium volume of fluids, and I'll come to a few take-home messages in a minute, then we get to fluid volumes, and everyone I know of has been interested in this trial. Came out in 2011 now, but if you give lots of fluid to African children, more of them die. Is this a budgie in the birdcage for all of us? People have wondered about adults. Do we need to give less fluid? I certainly think it applies in Africa. I've worked in Africa in Sierra Leone for a while with MSF, and in retrospect, I gave too many fluid boluses. You give a fluid bolus, you're lucky if a nurse is there overnight. You know, that you've got these 100-bed wards with the first 10 of them having GCSs of less than 8 because of their cerebral malaria, etc. Yeah, you're lucky if the nurse on the night shift turns up who's looking after 100 patients. That kind of environment giving fluids is dangerous. None of us know how we put that into our practice. But it's interesting. ILCOR have started to put that into practice against it. I think this is a really good statement. We suggest against the routine use of intravenous boluses for infants and children with severe febrile illness but who are not in shock. And again, with our emergency department colleagues, it would be good to get this message through that if they're not in shock, particularly, I can't remember the last time I saw a bronchiolytic who didn't get 10 mils per kilo of fluid for a reason I'm not quite sure why. So we need to think hard about this. Do they really need fluid for perfusion? The flip side of this coin is this, and the Australians might not know of this, but this is the meningococcal rate in Auckland over the past few decades. And my colleagues, well, two of them sitting here, saw the most incredible numbers of meningococcal sepsis you could ever believe. You know, the unit had dozens of them coming through. And so they've treated more meningococcal sepsis than just about any intensivist you'll meet. And they all, swear by the value of fluids. And we've probably all seen an occasional bacterial sepsis like that where we've flogged them with every inotrope you can give them at the highest dose you can, and without giving them lots and lots and lots of fluid, like 100 mils per kilo in the first 24 hours. There's no way we could have kept them alive. So, just because of feast, there's no way a child of the most severe septic shock could have lasted a few hours when I worked in Africa. This is not the group of kids that are really, well, they might have been that sick, but not with inotropes, ventilation, all the stuff we're throwing at them. So we keep, the whole reason that hypertonic fluids are bad comes down to ADH and SADH. I separate those terms. I dislike how we use SADH in someone who's massively volume depleted. It's not inappropriate. It's what your body is doing to survive. It's releasing ADH to hold on to fluid because that's what you need to live. There's nothing inappropriate about that. SADH to me is when you've got meningitis or tuberculosis or hypoxia. But when it's intravascular volume depletion, there's nothing inappropriate about it. But anyway, the same things. We've now got isotonic fluids, small number get SADH or ADH secretion. We make them hyponatremic. But of course that comes down to rate. No adult would go, oh, they've got SADH, so we give them isotonic fluids, but we'll give them at 100% of their maintenance rate. You've got to cut fluid rates back. Also note that our basal metabolic rate related to loss of fluids related to that humidification in the airways. And if you've actively humidified via one of these, that formula doesn't apply anymore. You're not losing that massive volume of water with breathing. And how many kids, when they're in a unit, are on these? High flow bubble CPAP. That'd be the majority of kids in general units throughout New Zealand and Australia from my experience. I won't go too much into this. There is differences in the renal physiology and fluids, but at the end of the day, you are born in renal failure and you have slightly difference in how you handle sodium. But at the end of the day, you've got less fluid being filtered at the glomerulus. but the body's designed to compensate for that. And basically, even though you've got lower GFR, you've got lower sodium absorption, and you treat a neonate like a little adult. Be watchful if you're giving isotonic fluids, which we all do, but there's slightly higher risk. Some of them will get hypertonic, but just like any patient, just watch carefully. You know, doing at least daily bloods is the standard of care for a child on IV fluids in your unit. I think we're running a bit behind. I've got a couple of quick vignettes. This is one who was not uncommonly come to a general ICU when I used to work in general ICUs. DKs, you'll know why they come to ICU in kids but not as adults. They get brain swelling. We don't understand the mechanism. It can kill them. Have a very low threshold for admitting young ones. They don't have to be that unwell at all if you're 2 or 3 to get in when I'm on. The important things are they come in with these really high sugars. The sodium, you have to do that corrected formula. There's about 3 different ways to correct, but you just basically subtract a normal BSL and then divide it by 1/3. So this will be, you'd add on about 10, so it's about 140. And this is what we normally do. We give them a saline bolus. We start the insulin. We run them on normal saline. Their sugar drops precipitously. They become drowsy, difficult to rouse. The whole reason they're with us is for cerebral edema. There's some interesting changing thoughts about this and difference in the way intensivists tend to manage these kids. But one of the easiest things to do is I now start glucose at the very beginning, even though the sugar is 35. I think that precipitous drop you get in the first hour or 2 is really bad for brain swelling. And it still drops when you add sugar to the fluids. If you're giving them 5%, it comes down, but it comes down over 4 or 5 hours rather than 1 or 2. And obviously, glucose goes across the blood-brain barrier, but it takes a while to equilibrate. It just gives you a bit more time to equilibrate. There's a lot of people who think they religiously need to have their 5% dehydration replaced over 24 or 48 hours. We always overestimate how dehydrated they are. You can always cut their fluids back and they still get better. If you're worried about cerebral edema, cut their fluid rate back. Obviously, always give them isotonic fluids. Of course, if you're giving normal saline, a lot of the endocrinologists move to NON2 because they're worried about the chloride once their sugars got down. They start with normal saline. It probably is one of the arguments for plasmolite, but we're hopefully running a trial soon to look at some of these issues. But plasmolite with glucose. But keep an eye on their chloride because it's obviously going to get confusing once you've got hypochloremic acidosis with their diabetic ketoacidosis. Insulin rates, you need to give some insulin, but you can always cut it back. If they're getting brain swelling, pull their insulin rate back. You can hold their ketosis steady, let things equilibrate, and then keep moving. But and just keep an eye on that fluid concentration rate. This will be straightforward for the paediatric people. This is just an interesting look. If you saw, this is about thinking about the fluids you use and how you use them and what you do as kids, as little adults. If you saw that in an adult, particularly in a fellowship exam, what would you think of? It's an Addisonian blood in an adult, isn't it? And this is congenital adrenal hyperplasia. There's a clitoromegaly there, which is basically the same thing. You've got low sodium, high potassium. In this case, they're acidotic. You should be alkalotic technically. We'll go through it. It can go both ways. It depends how hypoperfused you are, how much shock you're in as to what your pH is, but technically it does make you alkalotic. Lots of points in a pathway where things can go wrong, and they viralise because you've got more precursor here and it's being pushed this way to all your androgens. The interesting thing is you can, of course, cut these pathways at points where you're mineralocorticoid or glucocorticoid deficient only. But it's interesting, glucocorticoid kids don't get the hypokalemia and they don't get the alkalosis, but they get hyponatremic, and that's actually reduced renal perfusion and free water clearance, the same way someone in heart failure, they basically have a form of heart failure if you've got bad glucocorticoid deficiency. And it all comes down to the 88 secretion, the other mechanisms. So the treatment's exactly the same in terms of your boluses you need to maintain perfusion, you treat the underlying cause, which is give steroids, but often they need to be fluid restricted once you've got them on the mend, and always, on isotonic fluids. So the take-home messages, there's 3 slides here. Think hard about the need and whether they really need to be bolused. Keep going with early aggressive fluid resuscitation if they're really sick. Being wet, adults and kids, is bad for respiratory failure. You don't need to give heaps and heaps of fluids to kids who are in with respiratory failure. Isotonic fluids are what we should be giving, and most intensivists have been doing this for years, but we need to convince our paediatric colleagues to do the same on the ward. There might be some role for these for hypertonic dehydration, but you need to watch closely. Think, I'm not dealing with a meningitis or other things where I might want the sodium up a bit high. So the basic rule is 50 to 70%, and if they've got something like meningitis or impaired consciousness, go for the 50% of what you get with the 421 or 150-20 rule that you use. So a lot less fluid, and put the infusions in that. We often accidentally flood kids because the number of infusions we're running in them. They're and always move, like adults, enteral feeding is key, but of course enteral feeding is the equivalent of 4% and a fifth. There's a big drop in sodium, so watch their sodium at the time you move to enteral feeding. Dysnatraemias. Test and think as your adult patients. Like if you give the gas and say it's an adult, they'll usually get, an adult intensivist will get the diagnosis, but you get this mind block because it's a kid, but get over that. Just think of them like an adult. And same with, you'd not get an adult with a major dysnatremia and not test their urine osmolality and sodium, paired with their serum osmolality and sodium. Do that in kids and interpret it the same way. Very subtle differences in a very early neonate because they can't concentrate quite as much, but 99.9% of the time you interpret it in exactly the same way. Obviously in the massive extremes, call for help early. Yeah.